Welcome. We're glad to see you all here. Population health management went on the back burner throughout the pandemic, but now is the time to start thinking again about the longer-term strategies to improve child health. In the next hour, we hope to give you a taster for population health management with the hope that you will enjoy it sufficiently to incorporate some of the ideas into your clinical diet of the future. We will start with a short introduction, then an overview of population health management, followed by an example and a time for brainstorming topics. The case study is a time for you to take your ideas forward. And then finally, we want to think about how BACCH can support you in population health management. Before we start, let's recap the main points of the NHS long-term plan. Honestly, the NHS long-term plan was the best thing since sliced bread. It reversed the Lansley reforms and encourages cooperation and collaboration rather than competition. It puts clinicians at the centre of accountable care and embeds quality improvement. It majors on prevention and introduces the concept of population health management, all of which was further endorsed by the Hewitt Review some 2 years later. The 2022 Health and Care Act embedded the 4 central integrated care system functions into legislation. All are highly relevant to child public health. They are improving the population health and health outcomes, enhancing productivity and value, tackling all forms of inequity, and supporting the NHS contribution to the wider social and economic development of local communities. Personally, I would have put number 3 as number 2, but there you are. The 23-24 commissioning priorities are obviously COVID recovery, particularly waiting lists, implementation of the NHS long-term plan, the major conditions strategy, which includes much of population health management in action, and finally, NHS sustainability. The major conditions strategy might be a way for paediatricians to engage with ICSs and introduce child public health. It is estimated that 60% of all adult morbidity and mortality is related to these 6 conditions: chronic respiratory illness, cardiovascular disease, mental ill health, musculoskeletal disorders, dementia and cancer. So these are the ICS priorities. The strategy focuses on prevention, effective interventions and rehabilitation, largely relating to adult services. But we all know that most of these conditions have their origins in childhood. Indeed, the only way to succeed is through better prevention throughout childhood. On this slide I have included some of the issues that are equally relevant to children. On the right-hand side is air pollution, including climate change gases, better nutrition and obesity reduction, which also contributes to poor mental health and musculoskeletal disorders. Then on the left-hand side, dementia and cancer reduction through immunisations such as HPV, hepatitis B and emerging vaccine. The 2 big additional issues, top and bottom, are poverty and secure nurturing parenting throughout childhood. So what do we mean by population health management, and how does it differ from public health? My short answer is that it is public health for clinicians, to help them further improve outcomes for the patient groups they're seeing once they have optimised the clinical care pathway. David Kindig, who is acknowledged in the NHS long-term plan, has a more comprehensive definition as follows. Population health management focuses on the interrelated conditions and factors that influence the health of populations over the life course, identifies systematic variations in their patterns of occurrence, and applies the resulting knowledge to develop and implement policies and actions to improve the health and well-being of those populations. Population health management is evolving as a concept, but shares a subset of public health competencies. Public health tends to address issues for the whole population at one end of the spectrum, whereas population health management tackles the wider factors relating to subgroups within the population. You will remember that primary, secondary and tertiary prevention is included at each stage of the clinical pathway in the family-friendly approach, seen here as the red dots in the diagram bottom right. Promotion and protection are an integral part of the Progress Plus curriculum, expanded further as a duty of care for clinicians in GMC guidance. This is the first exercise. In pairs or threes, I would like you to think about what your top 2 or 3 priorities are for your service, and then click to continue. Exercise 2, a very quick question. How much does clinical care contribute to overall health? 5, 10, 20, 30 or 45%? What do you think? Yes, 20%, seen here in the Wisconsin County Health Attributes Ranking Model. This is the figure that appears in the NHS long-term plan, describing the importance of the wider determinants of health and the relatively small contribution that clinical care contributes to overall outcomes judged by length and quality of life. In some ways, the orange arrows in the centre represent a very simple life course pathway, with the health factors on the right, including the physical environment, social and economic factors, and individual behaviours, influencing the life course pathway along the way. Do please Google County Health Rankings Model for an excellent interactive resource based on the structure of this figure. I've included a link in the notes. I think it's useful when developing strategies to think about those factors that individuals have control over and those that are outside the control of individuals and require a more community approach. So on the left we have individual, population and services as the structure for the next slide, each of which may be either positive or negative. The message here is once you've provided excellent clinical care, then addressing health determinants is the next step in improving your outcomes. This is another representation of the previous slide for paediatricians who like growth charts. On the vertical axis we have quality of life, and on the horizontal axis duration of life. The pink circles represent health determinants that individuals have control over. The pale green circle represents health determinants that operate at a more community level. And finally, the blue circle represents services spanning at least health, education and social care. The upper and lower lines represent the combined impact of the individual, population and service structure, with the upper line being all positive and the lower line being all negative. The difference between the upper and lower lines represents the quality adjusted life year gap, or QALY gap, and is, in effect, the potential difference that tackling determinants could make. So now let's develop a little more detail. On the left-hand side are the hazards relating to both lifestyles and determinants, whereas on the right-hand side are the assets that contribute positively to health outcomes. I have omitted access to services in this slide, but the intention of services is to protect individuals from hazards and promote exposures to assets. While you are all familiar with pathogenesis, the other side of the coin is salutogenesis. Here are just some examples of potential hazards. At an individual level, this would include a poor diet, lack of exercise, and substance misuse, and at a population level, poverty, poor housing, and inaccessible services. Adverse childhood experiences, or ACEs, are stressful or traumatic events that can occur at any time throughout childhood. ACEs include all types of abuse and neglect, as well as parental mental illness, substance misuse, divorce, parental imprisonment, or domestic violence. Now on the right-hand side, we have assets related to lifestyles, which would include good relationships within the family, creative play, and safe housing. Then at a population level, would include a supportive community, affordable homes, and little deprivation. Adverse childhood experiences should be complemented by positive childhood experiences, but this as yet is not a concept that's been established. So I've included FACEs, which are favourable childhood experiences, covering good events in family lives, just as a reminder. These would include holidays, birthdays and family events. So, pulling all this together, there is a balance between the positive and the negative factors that influence life, mediated through education, relationships, life at home, leisure and work. The negative elements work together to contribute towards pathogenesis causing ill health, whereas the positive elements come together in salutogenesis to create resilience and well-being. This is the second most important slide in this presentation and could form the basis of an MSc or SPIN curriculum. It is loosely based on a PDSA cycle. I will start in the top left with purpose. What is the intention? Which populations are involved? What are the expected outcomes? Next is knowledge. Knowledge both about what works from an evidence base and also knowledge about the local population in terms of health, ill health and exposure to determinants. Next is the intervention. What needs to be done, by whom, when and where, and how will it be quality assured? Finally, there is learning from the process. What worked, what did not work, what were the implications for systems, workforce and finance? Now, let's look at a real-life example, in this case, following the death of a child with asthma. In the last slide, we took an orderly stroll around the population health management cycle in a clockwise direction. In real life, the situation is less straightforward. It may start with local knowledge that something is wrong, in this case 2 asthma deaths, the publication of a new way of working, a policy directive from central government, or a review of local services. Indeed, within the process of population health management, there is an overlap with quality improvement, leadership, communication and management competencies, all of which may be needed at different times and points in the cycle. The asthma example here will relate to the 4 steps: purpose, knowledge, intervention and learning. Purpose. Clarifying and agreeing the purpose with all stakeholders involved is an essential first step. High use of short-acting beta agonists is a marker of poor asthma control. Indeed, use of more than 6 inhalers a year is a known risk factor for fatal asthma. The intention here was to identify all children with asthma, check that they have an asthma review using the National Children's and Young People's Asthma Care Bundle. Knowledge. Here we have the number of inhalers on the vertical axis and all the primary care networks on the horizontal axis. The bar chart shows a range of inhaler use over 12 months, from approximately 2 up to 25. Just producing the data motivates networks to examine their practice. Was the 25 really true, or just a glitch in the system, for example? The graph does show at least a 5-fold variation, which is compatible with most other NHS variations. The question is whether this represents acceptable or unacceptable practice. Knowledge again. A similar approach can be taken with other variables known to be associated with poor asthma control. Here we have the number of exacerbations, numbers of prescriptions, asthma care and potentially lung function on the horizontal axis. The red, amber and green spots represent good, dubious and poor care. On the vertical axis we have the individuals with asthma with a big red arrow showing the boy who died, who had had 10 inhalers in the previous 12 months, no asthma review, no check of his inhaler technique and no care plan. So definitely time for improvement. Interventions. An asthma lead was identified for each network. A multidisciplinary group was pulled together, including a pharmacist, practice nurse, general practitioner and service manager, to deliver asthma training and lead the process within each primary care network. High inhaler use patients were identified and a clinical review of each child conducted using National Clinical Care Guidelines. And finally, learning. In this asthma example, it was important to bring primary, secondary and voluntary care groups together, combining their strengths for greater effect. Primary care professionals required refresher training, and this has now been further developed within Health Education England and e-learning for health. Ensuring that the data on inhaler use was accurate was particularly important for reasons of credibility. Ensuring that there were benefits for all the interested parties to secure their future commitment was an important element for success. Now, exercise 3. We would like you to take one example and work through it using the population health management cycle. So for your topic, you will need to clarify the purpose and the population, Identify the information you require, both evidence and local data. Plan what needs to be done, by whom. And finally, think about the barriers and incentives you need to consider before starting. Here is the framework for feedback. So now let's quickly recap this session. Population health management is set to become an integral part of clinical care. It requires collaboration between individuals, teams and organisations with a very clear focus on the problem to be addressed. It should be evidence-based, and like PDSA cycles, using a population health management cycle can be an aide-memoire. There are lots of sources of information listed here, but population health management is an evolving concept and different sources may emphasise different elements of the process. What we would like to do is to develop a learning network around population health management, and to do this we would like you all to join us at a later stage to plan the best way forward that works best for you. So we will be in touch. Thank you for contributing to this workshop, and we look forward to working with you. Thank you again, and we would welcome comments and questions on the content of this presentation, which should be viewed alongside the BACCH and BACCH paper entitled The NHS Long-Term Plan: What does population health management mean for services for children and families? Thank you.